Hi, I'm Dr. Michael Miyazaki, and today we've got an interesting case because in the past I've talked about some restorative techniques and I've talked about endodontics. Now, I know this is kind of a blown up image, but does this tooth need a root canal? So let me just kind of try to outline this for you. Here we go. So, patient shows up, young child and the mother. Well, the child's 14, maybe not that young by today's standards, but had a lot of decay in the first molars. This is tooth number 30 or the 4-6. And let me just outline the tooth. Not doing a very good job, but outline it right here. And I don't know if you can tell, but the pulp's right in this area, right here. And we've got deep areas of decay that extend right here. Don't worry, I've got some better images coming up. I'm just kind of setting this up. And you can see that on the occlusal, we've got a lot of decay here. So we've got all this area of decay. And tooth number 19 or the 3-6 was very similar. And so the patient had gone to another dentist. That dentist had recommended a root canal, and I think rightfully so. So the mother, concerned about the need for all these root canals, came to her office and asked, "Well, what other options were there?" I took a look at this radiograph and told her, "I think this tooth should have a root canal." But the mom said, "Is there anything else we can do? Like, I really don't want to have my son have another root canal." I asked, "Well, does the tooth hurt?" They said no. Had there been any symptoms at all, any sensitivity at all to bite, hot and cold, anything? Said no. So I said, well, one of the things that we could do is we have this filling material. It's a bioactive filling material that actually helps the tooth heal itself. So what we can do is we can remove all the decay, and I know we're going to be really close to the nerve, but we can remove all the decay in the infected part of the tooth structure and then place this bioactive material back into the tooth and just see how the tooth does. Now, what you have to understand, again, talking to the mother, what you have to understand is that this tooth has had these areas of deep decay for, I assume, for a long time. This was the first time I've seen the patient. And during that time, the bacteria has had a chance to infiltrate, to kind of soak into the pores of the tooth and get into the nerve. So the nerve might be irritated. But again, the patient wasn't having swelling, wasn't having discomfort. And being a young tooth, it had a lot of circulation. So I'm thinking, well, maybe the pulp has the ability to reverse any damage that's been done. And as a parent, I understand you don't want to have your kids have a lot of root canals. So I gave the patient that option. From that consultation visit, she left to think about it, and we gave her an estimate of the cost. And I really didn't know if we'd see the patient back. The patient had already seen another dentist, had come to us, and I thought, well, she may not like what I said and may never come back. But a couple weeks later, this child ended up on our schedule. So what I want to point out is that sometimes we have these radiographs and we think, oh, the most predictable thing might be to do the root canal and maybe perhaps a crown. But on our younger patients, we know that the root canal may do fine, but the survival rates of teeth with root canal sometimes is a little bit shorter than the natural tooth longevity. So if I could maintain the natural tooth structure, that was most of it that I could, maybe that would be better for the tooth in the long run. And as a parent, I would think the same way as this mother. So what we did is we talked to the mother, and here's the radiograph, and you can see the areas of deep decay on the coronal portion of the tooth. So we had areas of deep decay. I'm going to come back up here. You can see the decay is going down into the occlusal surface down here, and it's really, really large right in here. And when we look at the pulp right here, we're pretty close to the pulp. And we know that, the decay is going to extend further beyond what it looks like radiographically. So if this decay extended maybe down a little bit to about this border and maybe this to that border, we know we're going to be really, really close to where that, just going to switch over. We know we're going to be really close to where the pulp is, and that's not going to be a good thing. So we know we're going to be really close here. We know we're going to be really close here, and we just don't know what's happening to this pulp. Well, the tooth tested normal. And when we look at the apical areas of this tooth, there, you can see the PDL. There's a kind of a normal spacing. There's not a large radiolucency or anything like that on any of the apices. So again, the tooth tested normal when trying to do some provocation with a endo ice test. So when we placed the cotton pad on the tooth, the patient could feel the cold, and when we removed that cold, that sensation of cold went away. So the tooth felt the cold, and that sensation was transient. It wasn't lingering or anything like that. So that was a good sign. So the diagnosis is we've got a tooth with very deep decay. Possibly we're going to have an exposure as we remove that decay. And if that happens and it is extensive, I explained to the mother, then I would recommend endodontic therapy, the root canal therapy. So the mother understood the decay. The tooth, the sister tooth on the other side, tooth number 19 or the 3-6, had a root canal done to it. And so the treatment plan was going to be do a direct composite restoration using Regen, our bioactive adhesive and our bioactive composite liner to help the tooth heal itself. So that was our plan. It's going to be conservative. Worst case scenario, if the tooth goes south and the patient starts to have more spontaneous pain, then we can always do the root canal. But why not start out with trying to do a direct restoration? So if you look at the tooth from the outside, it doesn't look that bad, right? We've got some discoloration right here, and yeah, the occlusal uh, pits and grooves look a little bit stained, but overall not that bad. You look at the other teeth, not too bad. This tooth and the tooth on the adjacent side took the brunt of the caries exposure. So what I'm going to do as I'm getting into this, we numb the patient up really well, is I'm going to remove the infected dentin, get into the affected dentin. But if that affected dentin is firm and I'm scooping it away or using my slow speed burr or a high speed round burr, whatever it is that you use, and I felt like that was good, strong tooth, I would stop right there. And a lot of times what I'll do is I will remove the infected dentin, and that's kind of the leathery type of dentin feel. I'll remove it with either an excavator or a burr, and then I will keep removing it until that dentin gets to be kind of shiny again. So as I scoop it away, I'm just kind of scraping the surface, but I'm not taking big chunks of dentin away. And as I'm scraping it, you can kind of see the dentin surface turning smooth again. That leathery appearance starts to go away. So that was my idea of the preparation. So you can see here we're in that leathery area, and I just kept scooping away and kept removing the dentin until it was no longer that way, until we had good firm dentin. So now I move into the recipe of placing that bioactive restoration. So what I do is, if you look at the box right down this area, I was way down close to the tissue, and one of the things right in this area, so I was slightly subgingival once I removed all that soft affected dentin and the weak enamel in that area. One of the things I don't like is when I place my matrix and I get my wedge and my ring and everything in place and I'm ready to start etching, and all of a sudden the tissue starts to bleed, and that bleeding sometimes percolates up underneath my matrix and gets in between the matrix and the tooth. So one of the things I do right here before I even get started is I will just rub QuickStat Free, our clear hemostatic agent with all the surfactants in it. I'll rub that into that gingival margin there. And then when I place my sectional matrix, my wedge, my ring, I look down into that box, and typically I have no bleeding at all. So that's what I did in this case. I take my QuickStat Free, I rub it down there, then I place my sectional matrix, my wedge, and my ring. Now when I place my matrix, to ensure I get a nice tight contact, once the wedge and the ring are placed, I take a condenser and I rub the matrix up against the adjacent tooth. In this case, the distal, that second bicuspid, I kind of burnish it up against that tooth, so I know I'll have a nice, broad, tight contact. In this case, I could have used either etchant that I've talked about in the past. I could use Clean and Boost, which is our nitric acid etchant, but everything was pretty well controlled, so I used Velvet Etch. Velvet Etch is, again, our 40% phosphoric acid etch. I place it down in that area, so what I do is I place it on the enamel border first, and being an etchant that stays where you place it, I place it on the enamel border, so that starts to etch first, and then I fill up the dentin area. I etch it for about 15 to 20 seconds, and then I rinse all that out very thoroughly. One of the things I like about the velvet etch is it's very easy to place and very easy to rinse. So once I have that rinsed out, because we did not have an exposure, but I knew I was close to the pulp, I used Desensamax desensitizer. So I take my Desensamax, shake the bottle up to get all the goodies mixed up. Then I take my microbrush and I just place it down there and I let it soak in for about 20 seconds. I just place multiple coats just to allow it to soak into the dentinal tubules, and it re-wets the dentinal tubules at the same time. Lightly air dry that just so that it's not puddled anywhere. And then I applied my Regen Universal Adhesive. So I use a Universal Adhesive, and again, I'm taking multiple coats. I place on my microbrush, and I just place it onto the dentin and the enamel surface, and I place another coat. I place another coat, and if you want to air thin in between there, you can. But many times I just kind of gently agitate with my microbrush to work it into all those dentinal tubules. I want to give it time to allow the fillers to get into the dentinal tubules, because remember, we have the Bioglass 45S5, and that's going to help to create hydroxyapatite. So I just apply that and apply it, and then I lightly air dry it again to evaporate off my solvents. As I evaporate the solvent, that will make my adhesive layer a little bit thicker. Then I get in there and really, with more vigorous air, I thin out the adhesive because I don't want a really thick film thickness. I've already allowed it to get into those dentinal tubules with the Bioglass 45S5. Now that I've got thinned out, I use my Pink Wave curing light. And I cure that. I like my curing well done, so I cure for about 20 seconds. And remember, the Pink Wave curing light will cure to a depth of 8.5 millimeters. And in this case, we don't even have really any composite in this box, so I just need to have it be able to get down with enough energy to cure my Regen adhesive down at the bottom of that box. And the Pink Wave curing light has more than enough energy. It's very low profile, so even though this patient was a young patient, I could get that light down over that tooth. And as we cured it, and we've talked about this before in previous programs, is I didn't have any type of shadowing, so we cured that Regen adhesive very, very well into that preparation. Now I took my Regen Flowable Composite Liner. Now the Regen composite flowable liner has that Bioglass 45S5, and I think of this layer as being my reservoir of Bioglass 45S5. So I lined the box in my preparation, all those deep barriers, with my Regen Flowable Composite Liner. Now I can either thin it out. I just like to make sure there's no air bubbles in there, so I'll run my Explorer through the material, then I'll run it up against the walls of my preparation, and then I can cure that. Or sometimes what I'll do is I'll leave my Regen the Regen Flowable Composite uncured, and then place my sculptable composite over the top. In this case, we use the warm composite, the exquisite composite, in an A1 shade. So I place my flowable composite liner with the 45S5 in it. Then I take some warm sculptable composite, exquisite A1, and I place that into my flowable composite lining material, and gently, now with a composite placement instrument with my seam-free composite wetting resin, I gently kind of tamp it down so that it goes down into that box, so it goes down to the deep areas of the preparation, and I begin to sculpt it. And in the deep box area, I may sculpt like 2/3 of the depth, but then what I do is I take my composite and I take my composite instrument and I push it up against the matrix. So now I push it against the matrix, so I have my contact, and I have this thin spatula type instrument that I can put in the box, and so I can make sure that I get my material all the way down to the bottom of the box, that there's no air bubbles or voids, and then I run it up against the matrix so that it forms my contact up to about a marginal ridge height. Then I come back in there with my Pink Wave curing light and I cure that. So now I have my contact established. I've got my material going all the way down to the gingival floor of my box. I know there's no voids. Then I take a second portion of the exquisite composite, my sculptable composite. I place that into the box, again with my seam-free composite wetting resin that my assistant has placed on the back side of my glove, and I gently put just a little bit of that composite wetting resin. I don't need much, just a little bit on my instrument, and I go back and I just kind of push that composite down into the box, and then I start to create my occlusal anatomy. Once I have that all contoured, then I light cure for 20 seconds with my pink wave curing light. Because remember, it's going to cure down to 8.5 millimeters. It's got the 4 bands, so I'm going to make sure that I have enough depth of cure, but I'm going to minimize my shrinkage stress because we're using the pink wave curing light with that near infrared technology. Now, once that's cured, I remove the sectional matrix, the ring, the wedge, the matrix, all that's taken off. And then I go in between, so my axial finish lines and the gingival flora with the interproximal carver, just to remove any flash that may be on my margins. I try to have minimal flash, and that's minimized by having a really good, well-placed matrix. But sometimes there's a little bit of flash, so I just kind of carve that off. Or you can use like a 12 blade. So once I get all that excess off, now I come in with the pink wave curing light. And I'll usually cure for 15 to 20 seconds from the buccal, cure 15 to 20 seconds from the lingual. Make sure I got those areas, especially the deep areas at the bottom corners of the box, all cured really well. Again, I like my composite well done, right? No sushi composite, raw or anything like that. We want it well done. Now I get in there and I floss to make sure that I have a good contact, to make sure that I can get the floss in between, that we haven't made it too tight. Sometimes I make my contacts too tight. And so I want to make sure I can get the floss in between there. And then I adjust the occlusion. Now our occlusion should be fairly close at this point because I use my seam-free composite wetting resin to really get my occlusal contours exactly the way that I want it to be. So I ask the patient, hey, bite down really hard. I know it's hard to tell because you're numbed up, but go ahead and try to bite down really hard and then grind your teeth side to side. Not just side to side, but forward and back. I'm just going to kind of grind around on that tooth. So then we'll pick up any interferences, should there be any, either height-wise or in lateral excursive movements. And then we'll go back and polish everything up. Take off all those little blue dots. I use blue Arctic paper, so I need to just polish those off. I polish the axial margins to make sure that my composite restoration is flush with the tooth. And then I get in there and I just polish everything up on the occlusal of the tooth. And number 18 is one of the most important things. I tell the patient, you had a really, really big, deep cavity. It went very close to the nerve of the tooth. Fortunately, in this case, we did not expose the nerve, but what I did is I placed a filling material that is bioactive, and that means not only does it fill in the space made by the cavity, but this material will help the tooth heal. So there's going to be less of a chance of us having to do a root canal. And we did this restoration a few months ago, and up until now, that patient is still doing fine. So that is the power of these bioactive restorations. I've done a lot of these over the years since I started using the regen materials, the universal adhesive, and the composite flowable liner. So I've had really good success in doing this, and I hope that following this recipe, you will enjoy the same success. So on the far left-hand side, you can see, we had those areas of decay. Middle photos is how the prep was before I removed all the decay, but I wanted you to be able to see that infected and affected dentin. And then once we got it all restored, the patient has a nice looking restoration and it is performing really well. So this is a regen bioactive restoration that we placed in a young patient that we had informed and had been informed by even another dentist that they were going to need a root canal, and so far, no root canal. So if this were your young patient, or maybe even your child, would you not think that this was maybe the best thing that you could offer the patient? So I hope you got some good information out of this. I hope it's some food for thought. If you liked it, hit the like button, please. If you want to make sure that you keep getting these little bits of information, please hit subscribe. Subscribe is great. It just says let us know, or let you know when we have more programs coming up. And that is it. So again, we are trying to make a community of like-minded individuals. We're trying to do the best we can for our patients. And that's why I like to bring this information to you. We're sharing ideas, and if you have other ways or other thoughts about this, please share them. And we want to be a supportive community, so Please be kind with your comments. But we want to create a community of supportive clinicians. So hit the like, hit the subscribe, and I'll see you back in the next episode. Thank you very much.